In this video, I'm going to go over bipolar disorder and some of the really more high yield points on bipolar disorder. I'm not going to cover every nitty-gritty detail of bipolar, but just really the things that are really testable that come up very, very often when you're talking about this particular disorder. So starting out with the basic stuff, the epidemiology. So bipolar disorder affects anywhere between 1% and 2.5% general population, with estimates as high as 4 to 5% when you include the full spectrum of bipolar disorder. So if you include all the different specifiers and subtypes, you can get a much higher percentage of people who might be affected by this disorder versus the typical 1 to 2.5% that we see in the general population. The prevalence is similar across all racial groups and affects men and women equally, so that is a testable point and often comes up on exams, that the prevalence is similar across racial groups and affects men and women equally, unlike things like depression, which usually affect women disproportionately more so than men. There is high comorbidity, so you want to know the comorbidities that come with bipolar disorder, and those include anxiety disorders, substance use disorders, are more common in patients with bipolar disorder. So this is the nitty-gritty of the epidemiology. So what is the etiology? So studies show that there's about a 5% increased risk of bipolar in individuals who have a first-degree relative who has bipolar disorder. So of course this suggests a genetic contribution, but this is not like typical Mendelian genetics or something like that, where it's obvious that it's passed from, parent to offspring in a very, very systematic and easy way to understand. So it's more complex than that is the bottom line. There's some genetic component, but it's not the whole story. There's a lack of complete coordinates among monozygotic twins, so that suggests that there's environmental factors. So what we usually say about a lot of these things is that there's a genetic predisposition and some kind of environmental insults or environmental factors that also contribute to the disorder. With that said, some of the clinical features and things that you want to be on the lookout for. So most individuals with bipolar disorder tend to present in the depressed phase or the depressed state. So always be on the lookout and always screen any patient who comes in with depression for bipolar disorder for a history of manic episodes, right? Because a lot of times they're going to come in when they're very, very depressed, because that might bring them into the hospital. But you want to still make sure that you're not missing it and you're not misdiagnosing them with a depressive disorder when in reality this is just the depressive phase of bipolar disorder. A history of hypomanic/mania is defined as at least 4 days hypomania and 1 week of elevated irritable mood or irritable mood. So the bottom line here is that for a manic episode, you have to have at least 4 days of the following symptoms. And for hypomania, you have to have at least 1 week of the following symptoms. And those include elevated or irritable mood and a minimum number of symptoms characterized by the mnemonic dig fast. So the mnemonic dig fast actually comes from the speed at which a bipolar patient would dig a hole if they were put to the task. So if you were to tell a bipolar person to dig a ditch, they would do it really, really fast. So that's where the mnemonic comes from. And what are those symptoms that we're kind of screening for with that mnemonic? We're looking for distractibility, indiscretion, so lack of self-control, doing things that they normally wouldn't do, grandiosity, flight of ideas, increase in goal-directed activities, and a decreased need for sleep and talkativeness. In the case of the elevated moods of the patients presenting primarily with elevated mood, they need to have 3 out of the 7 symptoms, whereas if it's irritable mood, you want to have 4 out of the 7 symptoms to diagnose it.